Hi everyone, my name is Jary Carpenter-Branson and I am a pediatric emergency medicine clinical pharmacist at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. Today I am super happy to be with you today to explain some pediatric trauma pearls. I have no relevant financial relationships to disclose during the construction of this educational content. This is a brief overview of what we're going to talk about today. We're going to outline the practice essentials for pediatric trauma response, interpret pediatric-focused literature on the use of ketamine during rapid sequence intubation, especially on its impact on intracranial pressure management in children with traumatic brain injuries, and compare and contrast the efficacy of hypertonic saline versus mannitol in managing elevated intracranial pressure in pediatric trauma patients. Unfortunately, over the last decade, the pediatric trauma statistics have worsened over the last 10 years. According to the American Academy of Pediatrics, fatal traumatic injuries have dramatically increased, and fatality rates have increased by over 250%. This is associated with the dramatic increase in firearm injuries and poisoning injuries, with firearm fatalities increasing by 87.1% and drug poisoning fatalities increasing by 133.3% since 2011. The top mechanisms of injury for pediatric trauma patients are firearms, drowning, suffocation, drug poisoning, and machinery. So what do we do when we initially get these patients in the trauma bay, and how do we manage our pediatric trauma patients? Let's talk about some essentials for pediatric trauma response. So how do we manage a pediatric patient that presents to our trauma bay? We're first going to complete a primary and secondary survey as per ATLS, just like we would an adult patient. We're going to look at airway, breathing, and circulation. It's important to remember, though, that pediatric patients have different normal vital sign ranges depending on their age group. And PALS has a great reference that I've included to the right of this slide. It has each age group divided up by neonates, infants, toddlers, preschoolers, school age, pre-adolescent, and adolescent patients. There are a lot of different mechanisms of injury that we can see in pediatric patients, just like adult patients, and it's vital that we know what the mechanism of injury is so we know how to manage the patient appropriately. We can see blunt abdominal and thoracic trauma, traumatic brain injury, extremity and pelvic fractures, facial and eye injuries, dental injuries, penetrating injuries, and spinal cord injuries. But I want to bring particular attention to non-accidental trauma. Many times these patients present with unrelated chief complaints and may not even have outward signs of physical trauma. So it's very important, especially for pediatric patients that are not talking yet, to remember that non-accidental trauma is very common. Weight-based dosing is an extremely important aspect of managing a pediatric trauma patient. It can sometimes be a headache, but it's a great way for pharmacists to be involved at the bedside and help decrease pediatric dosing errors. There are a few ways that you can simplify the management of these patients. You can round to the nearest reasonable weight. Patient weight in these situations is very common estimated with Broslow tape, and a good example of Broslow tape is included to the right of this slide from the PALS Pocket Reference Guide. Bed weights can also lead to large errors in patient dosing for pediatric patients. Bed weights are very sensitive to things that may be sitting on top, patient care that's occurring during that time, or if the bed doesn't get zero correctly. Also, sometimes beds are set to pounds instead of kilograms, and this can lead to large pediatric dosing errors. It is helpful to have a dose rounding scheme available at your facility, and I've included a good example of one. For less than 10 kilos, you could round up to the nearest 0.5 kilos. For 10 to 49 kilos, you could round up to the nearest 1 kilo. And for greater than 50 kilos, you could use adult dosing. This is done different at many different facilities, but this is a good example of one. There are also numerous resources available to assist with the development of pediatric dosing references if you don't have those available at your facility. Of course, we can use Broslow tape, but there are new software available that can help your facility generate patient-specific code sheets. There is HandTevi and SafeDose available. Some EHRs also allow for generation of patient-specific code sheets, or you could also build your own Excel-based code sheet and use that to generate patient-specific code sheets. Management of hemodynamics during the initial phase of a pediatric trauma is just like for adults as well. We will use an initial fluid volume of 20 mL per kilo up to 1 liter of warm normal saline or lactated ringers, and we will repeat that up to 60 mL per kilo. However, fluid sometimes just isn't enough, especially if they're bleeding, and we may need to transfuse packed red blood cells, and we should consider that, especially if they're hemodynamically unstable or there is an ongoing concern for bleeding. Depending on your facility, patients could meet criteria for activation of massive transfusion protocol. Massive transfusion protocol can vary from facility to facility. I've included an example of my facility's massive transfusion protocol included to the right here, along with a picture of a level 1 transfuser. Transfusers can come in many different shapes and sizes, but Level 1, Belmont, and LifeFlow are very common brands of transfusers. MTP workflow is extremely important and helps coordinate as many resources as possible to help manage the emergency. My facility currently uses Code Blue response for every MTP patient to help obtain as many resources as possible. Our pharmacy considerations for pediatric patients is very similar to what you would do for an adult patient. So we're looking at the administration of calcium chloride, tranexamic acid, cryo, and factor 7 to help manage these patients. Another common obstacle that we encounter with our pediatric patients, especially our very small and tiny infants, is sometimes the volumes that we're trying to draw up are too small to measure. A good example is using fentanyl during intubation for infants. Here's an example. A 6-day-old female patient that weighs 3.5 kilos presented unresponsive to the emergency department, and the provider is requesting fentanyl as one of the sedation agents for intubation. Our dose would be fentanyl 2 mics per kilo, and the patient is 3.5 kilos, so our dose would be 7 mics. The fentanyl vial is 50 mics per mil, so the volume needed of that 50 mic per mil concentration would be 0.14 mils. Unfortunately, though, per ISO, the minimum accurate measurement for a 1 ml syringe is 20% of its nominal volume. So in order to accurately measure a dose with a 1 ml syringe, it needs to be more than 0.2 mils. This volume is too small to accurately measure with a 1 ml syringe. So how can we make this a measurable concentration and volume for the patient? We can create a fentanyl 10 mic per mil syringe by using an entire 2 ml vial or 100 micrograms and dilute it with 8 mLs of normal saline to a total volume of 10 mils. Using a syringe-to-syringe connector, you can draw up the patient-specific dose from the stock syringe you just created. We needed 7 micrograms of fentanyl, and we created a 10 mic per mil fentanyl solution, so our volume that we can draw up is 0.7 mils for the dose. That is a measurable dose with a 1 ml syringe. Some pediatric facilities utilize pre-made fentanyl 10 mic per mil syringes for their RSI kits. However, this may not be feasible for facilities that don't have a high volume of pediatric patients. So this is a very easy way that a pharmacist can get involved and help make sure that doses are accurately drawn up for your pediatric patients. All right, it looks like we've reached our first assessment question. What trend has driven the increase in fatal traumatic injuries in pediatric patients? Is it A, increased road traffic accidents, B, increased firearm or poisoning injuries, C, increased sports-related injuries, or D, increased high-level falls? And I'll give you a second to think about it. Okay, and now the answer is B, increased firearm and poisoning injuries. Of course, the first thing with managing a pediatric trauma patient is managing our ABCs. And of course, the first letter is A for airway. So let's look at how we manage a pediatric airway. Preparation before intubation is extremely important in pediatric patients. Management of hypoxia and hypotension before intubation can help prevent a cardiac arrest during the intubation process. Hypoxia is a large predictor of imminent cardiac arrest in pediatric patients, and it's extremely vital that we help prevent cardiac arrest during the intubation process by resuscitating before we intubate. Pre-medication selections are largely provider preference, and they have no clear evidence that exists that shows that any of this is beneficial to the patient. And most of the time, it just complicates the RSI procedure, so using it is not of much benefit to the patient. But some providers still like to use these in specific situations. The first medication that can be used is lidocaine, and that is used to blunt the rise in ICP during direct laryngoscopy by inhibiting cough reflex. However, this can cause significant hypotension after the administration, and these patients likely are already hypotensive and with minimal reserve. So we have to weigh the risk-benefit with using lidocaine before intubation. The dose that we use is 1 to 1.5 milligrams per kilo IV. Another medication that has kind of fallen out of favor in recent years for pediatric patients is atropine, and we use that in a dose of 0.02 milligrams per kilo IV with a max of 1 milligram. We still do consider using it in infants less than 1 year of age, patients with septic shock, and patients receiving succinylcholine for paralysis. I think many of you have probably seen the next two charts that I've included in this presentation from the Stallings et al. Article that's very commonly used for topic discussions for rapid sequence intubation. But I wanted to include it for completeness sake, as we use the same dosing for sedation and paralytics as you would use in an adult patient. So for sedation, we also use etomidate, ketamine, midazolam, and propofol for our patients. For our paralytic agents, just like in adults, we use rocuronium and succinylcholine occasionally. We use the same dosing in our pediatric patients as well. We will typically go on the higher end of the dosing range of 1 to 2 mg per kg for patients that are infants and children less than 2 years of age, but that's the biggest difference for pediatric patients. Preference in paralytic agents definitely varies from facility to facility. I will say that my facility is currently a rocuronium facility, and we do not use succinylcholine for most of our patients. Succinylcholine is associated with bradycardia and asystole when administered to children less than 5 years of age, and it has led to acute rhabdo, cardiac arrest, and death in otherwise healthy appearing pediatric patients due to undiagnosed skeletal muscle myopathy. There are also the general succinylcholine contraindications like personal or familial history of malignant hyperthermia, skeletal muscle myopathies, known hypersensitivity, acute phase of major burns, multiple trauma, extensive denervation of skeletal muscle or upper motor neuron injury, or severe hyperkalemia. Now we have a controversial topic that may not be as controversial with other pharmacists these days, but it certainly is something that I still face in the trauma bay and definitely still see pushback from physicians that may not have seen newer literature on this topic. And that's ketamine and elevated ICP. Ketamine was originally suspected to cause an uncontrollable ICP in patients, and this was found in studies from the early 1970s. Patients in these studies did not receive controlled ventilation, which we know now impacts ICP in patients. Hypoventilation leads to increased ICP due to increased cerebral blood volume. It's thought that the mechanism of ketamine and elevated ICP is due to large vessel dilation from elevation in PCO2 in non-ventilated patients and small vessel constriction from nitric oxide synthase inhibition. There have been multiple adult studies that show that this effect does not have a clinical impact, but there are very few pediatric studies available. One of the studies that looked at ketamine in elevated ICP patients was from 2009 done by Bar-Joseph et al., titled Effectiveness of Ketamine in Decreasing Intracranial Pressure in Children with Intracranial Hypertension. As with all pediatric studies, it was a very small sample size study and included 30 patients from ages 1 to 16. This also was a patient population that had intracranial hypertension defined as ICP greater than 18 millimeters of mercury who did not respond to first tier and second tier measures. Group 1 was patients that received ketamine to prevent further ICP increase during distressing intervention. Group 2 was patients that received ketamine as an additional measure to lower markedly elevated ICP that was refractory to first-tier and second-tier measures. This is the results of that study. The left diagram looks at the entire study population. The middle diagram looks at the population that received ketamine prior to potentially distressing interventions. And the right diagram looks at the population of patients that received ketamine in an attempt to lower markedly elevated ICP. Overall, ketamine led to an ICP decrease of 30%, which was statistically significant, and a cerebral perfusion pressure increase of 54 to 58, which was also statistically significant. Group 1 saw an ICP decrease significantly following ketamine administration, and ICP only increased greater than 2 millimeters of mercury during a distressing intervention in 1 of 17 events. Group 2 saw the ICP decrease by 33%, which was, again, statistically significant following ketamine administration. The final conclusion of the authors was that ketamine effectively decreased ICP and prevented ICP elevations during distressing interventions without lowering blood pressure and cerebral perfusion pressure. Ketamine is a safe and effective drug for patients with traumatic brain injury and intracranial hypertension, and it actually can potentially be a benefit as alternative sedative and hypnotic agents decrease blood pressure and may potentially decrease cerebral perfusion pressure. Another study that looked at ketamine and elevated ICP was done in 2023 by Laws et al. Titled Acute Effects of Ketamine on Intracranial Pressure in Children with Severe Traumatic Brain Injury. The population of this study was patients less than 18 years of age with severe traumatic brain injury who underwent ICP monitoring. Severe traumatic brain injury was defined as a persistent Glasgow Coma score less than or equal to 8 following injury, and these patients underwent invasive mechanical ventilation to maintain an arterial CO2 of 37 plus or minus 2 millimeters of mercury. 33 patients were included, 22 patients received bolus doses of ketamine, 127 doses were analyzed, and over 1,400 hours of ICP data was analyzed. This was a retrospective observational study, and patients received bolus doses of ketamine for sedation or as treatment for ICP crisis, which was defined as ICP greater than 20 millimeters of mercury for greater than 5 minutes. So here are the results. So you can see that in the B category, intracranial pressure had several points in time that there was a statistically significant impact, even starting from 0 to 5 minutes after administration of ketamine. In the D category, for cerebral perfusion pressure, you can see that the benefit on cerebral perfusion pressure occurred around the 60-minute mark after administration of ketamine. The author's conclusion was that ICP bolus administration was not associated with increased ICP in children with severe traumatic brain injury, and also ketamine administration for ICP crisis was associated with a reduction in ICP. And now we're at our second assessment question. How does ketamine affect intracranial pressure in patients undergoing distressing interventions? We have A, increased ICP and decreased blood pressure. B, decreases ICP without lowering blood pressure and cerebral perfusion pressure. C, no effect on ICP. Or D, only lowers blood pressure. And I'll give you a second. Our answer is B, decreases ICP without lowering blood pressure and cerebral perfusion pressure. Another aspect to managing pediatric trauma patients is managing traumatic brain injury, including using seizure prophylaxis and hyperosmolar therapy. In regards to seizure prophylaxis, infants and children have a lower seizure threshold due to immature neural pathways. Prophylactic treatment is suggested to reduce post-traumatic seizures within 7 days. The clinical guidelines only included 2 studies with large patient variation, and there is no evidence-based preference between Keppra and phenytoin. Wide dosing variations are seen between treatment facilities. Keppra is typically easier to administer and well tolerated, and my facility does the 20 milligram per kilo IV load of Keppra and then maintenance to 20 milligrams per kilo per day divided Q12 hours. Hyperosmolar therapy is another important topic when talking about traumatic brain injury in pediatric trauma patients. In the evidence included in the 2019 Pediatric Traumatic Brain Injury Guidelines, hyperosmolar therapy administered in the emergency department had no significant impact on patient outcomes. The fourth edition of the Adult Traumatic Brain Injury Guidelines informs the pediatric guidelines with studies comparing hypertonic saline to mannitol. The evidence that influenced these guidelines were based only on studies with 121 and 169 patients. Since the release of the 2019 Pediatric Traumatic Brain Injury Guidelines, there has been further research done in this area. In 2022, Kochanek et al. Released a study that evaluated the intracranial pressure measurements before and after hypertonic saline and mannitol treatment in children with severe traumatic brain injury. In this study, 1,018 patients were screened and 518 patients were included for analysis. Of the 518 that were included for analysis, 339 patients were treated with hypertonic saline boluses, and 105 patients were treated with mannitol boluses. This was an observational comparative effectiveness research analysis and used data from the Approaches and Decisions for Acute Pediatric Traumatic Brain Injury trial or the ADAPT trial. The inclusion criteria was patients from birth to 18 years of age at the time of injury with a diagnosis of traumatic brain injury, with an ICP monitor that was used as a part of standard care, and a Glasgow Coma score of 8 or lower at the time of monitor placement. Looking at the results of this study, you can see that hypertonic saline was associated with a decrease in mean ICP and an increase in mean CPP, and that was statistically significant. However, mannitol did not have a statistically significant impact in mean ICP and mean CPP. In the unadjusted analysis, hypertonic saline was associated with a larger observed association with ICP than mannitol. However, after adjusted analysis, observed associations of the two agents were not different. Osmolar load was 1.88 times higher for 3% hypertonic saline, but the maximum serum osmolarity observed was lowest in patients that only received hypertonic saline. The conclusion of the author is that the bolus of 3% hypertonic saline is associated with reduced ICP and increased CPP, whereas mannitol was only associated with increased CPP. After adjustment for confounders, both agents were associated with decreased ICP and increased CPP. During increased ICP periods, 3% hypertonic saline was associated with greater improvements than mannitol. And now we have our final assessment question. In the context of the 2019 Pediatric Traumatic Brain Injury Guidelines, what was the conclusion regarding hyperosmolar therapy administered in the emergency department? Was it A, it significantly improved patient outcomes? B, it has no significant impact on patient outcomes? C, it was found to be more effective than alternative treatments? D, it is only effective in adults? And I'll give you a second. So the answer is B. It has no significant impact on patient outcomes. In summary, prevalence of fatal pediatric traumas have steadily increased, highlighting the importance of pediatric readiness at non-pediatric healthcare facilities. Utilization of pediatric resuscitation dosing tools and familiarization with pediatric pharmacy practice can help improve outcomes. There is emerging evidence on the use of ketamine in traumatic brain injury, and it has highlighted the usefulness in the care of trauma patients despite years of contraindication. And finally, the ADAPT trial in pediatric patients with traumatic brain injury has shown improved quality of evidence in the use of hyperosmolar therapy since the release of the 2019 Pediatric Trauma Guidelines. Here Here are the included resources that was utilized during the construction of this educational material. And I am here and available for any questions, comments, or discussion regarding the content of today.